All right, good morning, everyone, and welcome to the AcademyHealth Surgical and Perioperative Care Interest Group webinar on optimizing the delivery of surgical telehealth. This is a recorded webinar, and the recording will be published on our website, and it'll be sent to registrants as well. We have some exciting talks by our experts in the field lined up for you, and it'll be packed from the first minute to the last, so I'll get right into introducing all three of our speakers. Our first speaker is Dr. Caroline Reinke. She's an associate professor at Carolinas Medical Center and is Atrium Health's NISCRIP collaborative leader, its surgical quality officer, and the MAC clinical work group for the National Quality Forum. She'll be speaking to us about virtual versus in-person virtual visits for post-operative follow-up. Our second speaker is Dr. Chandy Ellimoottil. He's an assistant professor at the University of Michigan. He's also the director of the Institute for Healthcare Policy and Innovation's Telehealth Research Incubator, where he directs a portfolio of research projects focused on optimizing telehealth delivery. He'll be speaking to us about telehealth's impact on access, cost, and quality. And our final speaker will be Dr. Meredith Sorensen. She's an assistant professor at Dartmouth-Hitchcock Medical Center. She's a national authority on surgical education and is the education committee chair for Dartmouth and is the associate editor for the Journal of Graduate Medical Education. This year, she's serving on the audit committee for the New England Surgical Society, and she'll be speaking to us about the public's perception of utilizing telemedicine for surgical consultations. So without further ado, we will start with Dr. Claire Reinke's talk, and Dr. Claire Reinke, the floor is yours.
All right, good afternoon, and thank you everybody for the opportunity to start off this really exciting webinar about telehealth and surgery. I'm going to get us started by looking at virtual versus in-person visits, specifically in the post-operative follow-up with a brief overview and then some of the work we've done here at Atrium Health. I have no financial relationships to disclose. This research was supported by a research fellowship by the American College of Surgeons. And for those of you who haven't done this, doing a randomized control trial is a pretty intense team effort and certainly couldn't have done it without my colleagues, co-PI Kristen Harkey and our research coordinator. So the overarching question that we're talking about today is, can we take the technology that we use every day to talk to our friends and family, combine it with the medical care that we've traditionally provided in the office, and create a new paradigm of care in which we provide virtual care for our surgical patients? Here at Atrium Health, we've been doing telehealth for over a decade, and you can see that despite many years of expansion, our work here had primarily focused on on-demand care and had not been expanded to the surgical space. So in 2016, we decided to explore both of these options by utilizing virtual care for our post-discharge follow-ups. Some at our institution thought that surgery was maybe the ultimate non-virtual field, and I think we all know that that's not the case. And in fact, we've been using virtual care across the spectrum. But when we were looking at this initially, using the 5 phases of care as defined by the American College of Surgeons, that post-discharge visit seemed to be the optimum place to start our work. Unique to that post-discharge visit, many patients, when we've done our best and they've done really well, are doing well, and coming into the visit may be actually seen as a burden without a particularly tangible benefit to the patient. Yet, we as surgical providers think it's important to check the wounds, discuss questions, review pathology, and oftentimes this is an opportunity to evaluate health maintenance and make sure that that is all up to date. So the question was, could virtual care combine these two in a way that allows us to care for our patients adequately, but also meet their needs in terms of access to care? When we drew out all the steps that it takes for a patient to leave where they were at that point in the day, come to the visit, and then return back to their day, it actually ends up being a significant component of the patient's day just to come in for this visit. And you can further break out the time in the physician office to several distinct components as well. We were really interested in, could we focus on the care that was provided in the physician's office in a virtual way and bypass all the travel that happens before and after an in-person visit. So there was a fair amount of research that happened in this space prior to conducting our trial. Many of them were similarly focused on the post-discharge space. That seemed to be the easiest way to enter into this. and a lot of pilot studies looking at feasibility and patients' acceptance of this as a modality. One of the larger studies that came out actually after we had begun our randomized control trial was this pilot study to evaluate the use of telemedicine in postoperative care. And they had patients who underwent these eligible operations and offered them the option for an E-clinic or a T-clinic for their 2-week postoperative visit. And you can see that about a third of the patients chose the E-clinic, and there was no difference in this fairly large cohort around postoperative outcomes or complications. But it's important to remember here that we're comparing patients who chose to do the virtual visit to those who did not. And there certainly may be inherent differences in those populations that aren't measurable with our usual data sets. And in fact, the authors of this paper acknowledge the presence of a significant selection bias due to the non-randomized nature. So we designed a randomized control trial to look at the safety of post-discharge virtual visits for surgical patients, aiming to assess the non-inferiority and safety of post-discharge visits, hypothesizing that there would not be a significant increase in 30-day hospital encounter rates. And for that, we included ED visits, inpatient admissions, and observation admissions. We were also interested in the total time commitment, a common component of assessing the impact of virtual care. And we also wanted to look at the impact of virtual care in postoperative follow-up rates. We knew from our historical data that within this patient population, it was somewhere around 70%. So we designed a randomized control trial for patients undergoing low-risk, minimally invasive surgery, laparoscopic appendectomy, or cholecystectomy. Patients were approached, and those who enrolled were randomized 2-to-1 into our virtual care group or our in-person group. And immediately after their visit, they got a survey asking about their experience and another one at 30 days, as well as a review of their medical records to identify any potential complications that may have happened that we weren't otherwise aware of. Again, our focus here was really to make sure that we were capturing any adverse events that may have been related to the virtual care. As you can see, we screened over 1,600 patients with several being excluded and about 440 patients choosing to participate in the study. Our target enrollment was just over 700, and in fact, we didn't get to that primarily because we were at this point when COVID hit, and we felt that the in-person option was no longer equally safe, and we decided to shut down the randomization at that point. So we had just under 300 patients allocated to the virtual visit and about 150 allocated to the in-person visit. One of the things we found interesting about this, and will come up probably as we go through this webinar, was we did have 289 patients who declined to participate. While some of those were because they just didn't want to do research, it was interesting because it was a much higher percentage of patients who didn't want to do it compared to when we had done some preliminary studies in our clinic. And the interesting difference in that is that when we did our preliminary work, we asked patients who were in our clinic afterwards if they would have been willing to do that as a virtual visit, and 88% said yes. When we asked patients while they're in the hospital recovering from their surgery or potentially in clinic beforehand, that number was lower. And I think there's a difference there related to the patient confidence and what their recovery was going to be like. So when we look at our primary outcome of 30-day all-cause hospital encounters, they were not difference between the two groups. In fact, they were pretty darn similar at 13%. And these are all-cause visits. And that is pretty similar findings whether you look at the intention to treat or the completed allocated intervention. Because we didn't reach our target enrollment, we did do some simulation studies, again, sort of confirming our findings that the chance of there being a difference here was pretty darn low. So we were excited to see that hypothesis was confirmed with the work that we had done. When we looked at the secondary outcome of time, even in our virtual visits, there's a component of the patient experience that includes check-in and waiting, whether it's in a physical room or a virtual room, and then the time spent with the surgical team. And we wanted to look at those two components in comparison to the overall time and see if we saved time for the patient not only in the travel, but also in the time that they spent getting their medical care. So when we look at those components, similar to the other studies, when you look at the total time commitment, there's a dramatic decrease when you include the travel time. But when you look at the time that they spent with a surgery team member, it was about 8 minutes in both settings. So again, these are low risk, minimally invasive surgeries, but they're not different between the two. And the time that they spend from check-in to check-out was actually dramatically different, suggesting that our patients that come in person are spending more time waiting in the waiting room and waiting in the exam room compared to our virtual visit. Oh, and then our third aim here was to look at the percentage of patients who came to their postoperative visit. And it was actually pretty similar between the two groups, suggesting that patients who don't come aren't going to come no matter what type of visit you schedule them for. We also wanted to look at the patient perception of this, and satisfaction and convenience, I think, are sort of a minimum standard for evaluating a new way of delivering care. We also did a qualitative evaluation of free text responses. So we asked in the survey that was delivered immediately after the visit, how would you rate your satisfaction and convenience? And what did you like most about it, or what were your ideas about how to improve it? When we did this assessment, we looked at the groups a little bit differently because we had both the groups who completed their allocated in-person or virtual visit, and then a substantial group that did crossover from the virtual to the in-person group. And we wanted to look at those in particular to understand their experience. When you look at satisfaction, it's not different between the three groups. It sort of boils down to, did you get good medical care and feel like you were well cared for? And it turns out that's pretty good in all settings. The convenience, again, not shockingly, was much better in the virtual visits compared to the in-person group. And then what I found the most exciting about this work was the qualitative analysis. So when we looked at responses, the free text responses from the different groups, it turns out that no matter what type of visit you have, it's most important that you have quality interactions with the staff, you perceive that your care is excellent, and that you're receiving prompt and efficient care. I think, in this modern day and time, that's important to all of us. The barriers, though, were a little bit different depending on what group you were in. The in-person visits, not shockingly, the parking and commute. For the virtual visits, there were people who had varying levels of comfort with the virtual format. We tried to make this pretty darn pragmatic. And so if you could do the visit, you were included in this, and there were people with different levels of comfort actually using the technology. And that showed up in our free text responses. Some of the comments that were left by our patients included being able to do this from work. So we certainly, any of you who do virtual visits, see patients in some interesting scenarios. And then patients who otherwise wouldn't have been able to come to clinic because they were caring for their grandchildren, or wouldn't have otherwise been able to get transportation. There were, of course, people who felt like the virtual visit was fine, but they really did just want to see the surgeon. Or who had technical challenges and felt like that impacted their experience. For the in-person group, again, having surgeons look at and feel your incisions was important to some people, but then those who had that experience where they waited longer than they spent with a provider felt that that may have not been a benefit that was worth what they invested in it. So ultimately, we concluded that from those survey responses that access to care really is a critical component for patients, whether it's virtual or in person, and that those barriers are just different. And if we're interested in providing the best care and patient-centered care, we have to understand those and how to overcome them. And that as virtual visits spread, it's really important for physicians to partner with those who develop the virtual platforms to understand how they work and how we can make them patient-centered. Obviously, since the time of COVID, so we started this study in 2017, there's been a lot of changes. So the lifting of the restrictions on the MD licensing, you can see here with the Interstate Compact, we in North Carolina are not currently part of that. We are on the North Carolina-South Carolina border, and to provide care outside North Carolina requires separate licensing. And then there was some relaxing of the HIPAA regulations, particularly in the early times of COVID, so people could just reach out to patients whatever way they were able to. So in summary, in this study, it was really the first randomized controlled trial looking at post-discharge surgical visits in this setting. We did find that there was an equal 30-day primary endpoint. It was non-inferior. There was more convenience, equal satisfaction, and at the end of the day, access to care was important for the patient experience. Obviously, there are limitations. It may not be generalizable to other systems or different procedures, and that's some of the work we're still learning. We didn't reach full enrollment. There was a high crossover rate, and we were unable to understand how to reach those who chose not to participate. Really interesting to see what that experience was like in the COVID times where they couldn't choose to do the in-person so much. But overall, we thought that being able to have a randomized control group shed some valuable light on this question. So thank you all. I'm excited to hear the other talks and happy to answer any questions at the end.
Thank you for the wonderful talk, Dr. Reinke. We will get to the questions at the end of the session. And so we're going to move on. And without further ado, up next we have Dr. Chandy Ellimoottil as our second speaker. Dr. Ellimoottil.
All right, thanks so much for the introduction. And that was a great talk, and congratulations on completing a randomized controlled trial. I really like the slide where you have your whole team there. I know it's very difficult to do, particularly with digital health intervention. So my research is at a different level. It's at a population level. So the majority of research that I do is at the population level. And so this talk is specifically going to be looking at evaluating the impact of telehealth on healthcare access, costs, and quality at a population level. So you heard a brief introduction to me. So I have three different perspectives on telehealth. One is clinical. I'm a urologist. I've been performing video consultations with patients since about 2016. I've seen the lens from the operations side, where I've helped the program at Michigan Medicine grow. And then most relevant to this talk, I have a research lab called the Telehealth Research Incubator. And since about 2018, we've been looking at the population level impact of telehealth on access, cost, and quality. And so as a health services researcher, the goal here is to help inform state and national policies on how telehealth should be implemented post-pandemic. And so for the interest of time, I'm just going to dig right into the research, and I'll talk about the impact of telehealth, what we found, and how we're studying telehealth and access, telehealth and costs, and also telehealth and quality. And so first, regarding access, I think a lot of times we take it for granted that telehealth can improve access. Yes, it has the potential to improve access, but the relationship between telehealth and healthcare access is often complex. Perfect example of this is the recruitment in the previous study, how there's many patients that just weren't able to use telehealth. So when we think about access at a population level, there's the 5 A's of access that are considered. So affordability, availability, accessibility, accommodation, and acceptability. So is the technology affordable for the provider and for the patient, particularly in small rural clinics? Is it available if you're trying to reduce emergency room visits? Do you have the technology available at 2 a.m. when the patient is going to otherwise go to the emergency room? Is it accessible? This is particularly important for older patients. Does it accommodate, and is it acceptable? So do patients want to hear the diagnosis of cancer through video visits? Is it a better experience for them? Is it an equal experience, or do they feel like it's an unacceptable experience? So all of these subdomains of access have to be covered if telehealth is going to improve overall access. There's a million different ways that you can study this, and we are particularly interested in these three themes, or three lines of research. One is to understand factors at a population level that influence the use of telehealth to come up with policy targets. Number two is looking at population level metrics of outcomes, quality outcomes, and looking where there are actual disparities, like racial disparities, for example, and seeing if the exposure of telemedicine reduces those disparities. And then number three is looking at workforce shortages, areas where telehealth would be very beneficial, and whether or not the supply of providers providing telehealth into those areas actually increases access. So these are the three lines of research, and I'm going to talk about the first and third with a couple example studies. So this is a study that was led by Julia Chen and I, where we looked at predictors of the use of video versus audio-only telehealth use. And this has a lot of policy relevance because current US law does not allow Medicare to pay for audio-only telehealth. Of course, this was an exception during the public health emergency, but afterwards, CMS will not cover audio-only telehealth for evaluation and management visits. So our research question with this project was to understand what are the specific demographic, socioeconomic, and geographic factors that impact the use or predict the use of video-only telehealth. And you can see why it would be important to understand that as we're thinking about what the policy should look like after the pandemic. And so the design of the study was simple. We used health system data, and our study period was from April to June 2020, so early pandemic. During that time period, patients had the choice of doing in-person care, deferring care, conducting a video visit, or a telephone call. And our health system was well equipped to do video visits, and that was encouraged. So when patients chose telephone calls, they weren't necessarily doing it because they felt like they were getting better care. They were doing it because they didn't have, most likely didn't have the access to perform a video consultation. So that was the population that we wanted to look at to see who's going to perform video visits and who is more likely to perform telephone calls. So the first thing that we did was we looked at what we thought may be some predictors of this, and we put these variables together in a multivariable analysis, and we calculated something called an average marginal effect. So an average marginal effect is when you look at an individual variable and you look at what the independent influence of that variable is on the outcome of interest. This particular outcome of interest was the use of video visits. So we looked at these variables and looked at which one of these variables will predict using video visits versus audio visits. And so the strongest predictors of not using video, so more likely to use audio, was age, as expected. Within race categories, we found African American, needing an interpreter. And so we had video interpreter services available. So, there's other reasons why the populations that needed interpreters may not have been using video consultations. Medicaid status, and remember that Medicaid was covering video visits during this time period, and then also low access to broadband. So these were the particular categories that we found where there was a lower probability of using video. But taking it a step further, we ended up calculating a predicted probability for every patient that was in our population to understand how these individual factors can have a cumulative effect. So if you take a reference case of a patient that is young, their parents are helping them, non-Medicaid, need an interpreter, there's about a 90% chance that they'll perform a video visit. As you add on factors like being over the age of 65, 65 with Medicaid, and then 65 with Medicaid and needing an interpreter, that predicted probability drops to 19%. So the important thing here is that not only do people have risk factors against using video, but then these risk factors can compile and there's a cumulative effect. So we went and took the predicted probabilities for each individual patient in our data set and plotted it to understand our population. What's the likelihood that they're going to use video versus not using video? And this is the distribution for our health system. On the y-axis are brackets of predicted probabilities, and on the x-axis is the number of patients that fit into that probability bucket. And you can see that there was a wide distribution. There's a lot of patients that have a high probability of using video and a low probability of using video. So this type of analysis is useful, and this is where our research is going now, is to understand particular populations. So let's take two counties, County A versus County B. And in County B, there's a disparity, there's a need, there's an opioid epidemic, and then there's a need for addiction psychiatrists to provide care in those areas. So in one way, you can think that telehealth can improve access and reduce that disparity. But the important part of that is to understand who is the population that lives in that area. So if County B actually has a population that has a low probability of using video, then improving video access or improving or expanding health system access or video visit access may not necessarily reduce that disparity. So this is what we're doing at the patient level to look at how disparities can be mitigated through telehealth. And now I'm going to switch gears and talk about the provider level. And so this was that third line of research that I mentioned, where we are trying to understand the supply and demand between the need for telehealth and the accessibility of telehealth or the providers that are providing telehealth. And so telehealth has the potential to improve access to care barriers, particularly in areas where there's workforce shortages. The research question we had, and we used urology as the tracer condition for this study, it was led by Rebecca Howland, who's one of our outstanding medical students, was to understand whether or not the providers that were providing telehealth are actually providing telehealth to areas that need it, so to areas that are rural in this particular study. We used Michigan Medicare data for the early part of the pandemic, first half of the year, and our analysis was at the health service area level. And I won't get into the details of how that was calculated, but essentially we're looking at areas where patients receive care. And so if you think of a patient that needs specialty care that lives in a rural health service area, they have a couple options for care prior to the pandemic, prior to the expansion of telehealth. They could either get local care, so they can go see a urologist that's within their health service area, or they can drive outside of their health service area and see an external urologist. So a local urologist versus an external urologist. After March 2020 and the wide adoption of telehealth, there was this third option where a urologist that's outside of that health service area can provide telehealth care into that area. And that was actually what we wanted to understand the most, was how did the behavior of individual or providers that were providing telehealth, how did that change, and how many of them were providing care into these rural HSAs? And this was our first look at the data, is that we found that with the pandemic and with the increase in telehealth, there was a substantial percentage of providers that were providing care into these rural health service areas. So the blue bars represent local care. And so local care from January 2019 through June 20th stayed the same. And the bars represent the proportion of providers, or urologists in this case, per 1,000 patients that need urologic care. So that stayed consistent throughout. But then you can see in March, April, May, June, the percentage of providers outside of that health service area providing telehealth care into that area increased. So we're still waiting for more Medicare data to come in to see how much that trend continued, but this is kind of the story that we're creating. But there is more to this story. So when we looked particularly at these individual health service areas, we looked to see whether or not individual health service areas saw an increase in care. The blue dots represent the care that was there local without telehealth. And then the green care represents, once telehealth expanded, how much care was available to the people that live in that rural health service area. So for some parts, and this is all in the state of Michigan, so for some parts of Michigan, at the top part of this graph, you can see that they went from having 0 local providers to having 6 urologists per 1,000 people that need urologic care because of telehealth. So great success stories. But then as you go further down that graph, you can see that there were areas that had no local urologists and then also had no telehealth care, even though these patients had urologic diagnoses. And so that means that there are areas, even within rural areas, that have low penetrance of telehealth. So if you take those areas and map them out, and anyone that knows the state of Michigan, this is probably no surprise to them that it's the Upper Peninsula, the area that is extremely rural, that has the lowest access to telehealth. And so this methodology helps us figure out what are the priority areas or priority geographic regions where we need to expand telehealth if we are going to use telehealth to improve access to care. So that's all I have to say about access right now. And I'm going to pivot and talk about healthcare costs. So healthcare costs, it's very important for us to understand the impact of telehealth on healthcare spending, because it impacts how the Medicare program will think about telehealth after the pandemic. And I won't go through all the different thoughts on how telehealth can lead to increased costs and how it could decrease costs, but I will stick to the third perspective here, which is at the payers level. There is a chance that telehealth can cause costs to increase, and then there's also this probability that, or this chance that telehealth can cause costs to decrease depending on how it's used, if it's used as a substitute or if it's an additive service. So our research group is looking at this through multiple themes, just like we are with access to care. Particularly, we're looking at rates of episodes requiring downstream care. So you have a telehealth visit, it's insufficient, so you end up getting more visits downstream. Return visit interval, which means that are you seeing patients more frequently? That's going to lead to increased healthcare spending. Is the telehealth being used as a substitute, or is it an additive service? These are some of the research themes that we're using to look at telehealth and healthcare costs. This is a study that I'll just mention briefly. It was published in Health Affairs last month, where we looked at telehealth and downstream care. So we were particularly interested in patients that present with symptoms of an upper respiratory infection that are getting telehealth and seeing what happens downstream. Is the visit sufficient? And do they end up having their issue resolved, or is it unresolved? And then they end up having to have second telehealth visits, second office visits, or urgent care visits. So the comparison group was in person for upper respiratory infection versus telemedicine for upper respiratory infection. And what we found was that about 90% of these encounters, whether it was in person or whether it was through telemedicine, was resolved. Telemedicine did have a higher rate of follow-up. So that difference was 10% versus 6%, meaning that 10% of the visits that were initiated initially through telehealth required some sort of downstream care. And it was mostly office visits and telemedicine visits versus 6% of care that was initiated through in-person. Whether that's a small number or a big number really depends on the stakeholder and the perspective that you have, but there is certainly a difference that we found between the two different types of modalities. And I think this is just one small piece of the puzzle. I think we need to continue to study this in this way to see at a population level if there's going to be a difference in the amount of downstream care and therefore the downstream costs associated with telemedicine. And I won't get into quality in this talk. I think that healthcare quality at a population level is going to be important to study. I think it's hard to do that right now at a population level with particularly with claims data because of COVID. There's still a lot of, we haven't quite gotten back to usual care quite yet. But one thing's for sure, it's just not telehealth itself that's going to improve quality. You need to have some sort of underlying mechanism. Is it because of increased access to providers? Is it because of self-management? What's the underlying mechanism that can improve clinical outcomes? And one area that we're starting to investigate, and I won't get into the details of it, is to look to see how telehealth can improve hospital rates for conditions that are called ambulatory care sensitive conditions. So things where outpatient care could lead to lower rates of hospitalizations for CHF, for congestive heart failure, for COPD, diabetes, and those types of conditions. And more on that to come in future talks. But I'll leave you with this quote from Tim Cook. It's one of my favorites. I put it in every one of my talks. It kind of gives us the mindset of how we should think about telehealth research. It's not the technology, it's what are you doing with the technology. Technology is capable of doing great things, but it doesn't want to do great things. It doesn't want anything. That part takes all of us. And thank you for the opportunity to talk.
Thank you for the fantastic talk, Dr. Ellimoottil, and thank you for your important work on making sure the introduction of a new technology doesn't widen the pre-existing disparity in patients' access to care. For our final speaker, we have Dr. Meredith Sorensen closing with what the public thinks about our transition towards telehealth. Dr. Sorensen.
Sorry, I couldn't figure out how to unmute myself. Zoom faux pas. Can you guys see my screen okay? So thank you. It's a tough act to follow to bring up the rear with these two excellent panelists, but I'm excited for the opportunity to talk about our work on the public perception of telemedicine for surgical consultations. As we have just heard, Dr. Reinke has elegantly demonstrated that virtual postoperative follow-ups can be extremely effective, and Dr. Ellimoottil has made such a compelling case for the potential of telemedicine to improve access to care and for the potential for telemedicine to impact cost and quality. But what do our patients think about it, or our potential patients? Prior to the pandemic, most people hadn't really personally experienced telemedicine, but the pivot to widespread availability of telehealth services happened within days of the social distancing advisories and stay-at-home orders. And there was rapidly increasing awareness that it was even possible to see your doctor virtually. So what had once kind of garnered occasional gee whiz stories in the mass media suddenly was commanding headlines from major news outlets, and the coverage was generally positive. The benefits to patients really seem pretty clear, and we've talked about some of these already today, but especially for established patients with established problems, this model really makes a lot of intuitive sense, pandemic or not. But the relationship between surgeons and our patients is really intense and intimate. And the mutual decision for a surgeon to operate and a patient to agree to have an operation is predicated on a lot more than just informational exchange, and really relies on intangibles that may or may not come through on virtual platforms. As we've talked about, there's been really high patient satisfaction with telemedicine reported in the surgical context predating the pandemic, but mostly this has been in the post-operative setting. And there have been a few pre-pandemic studies demonstrating the feasibility of telemedicine for general surgery, although a lot of these were in limited settings, rural settings, or specific populations. And we're really, several of them focusing on telemedicine as a means to pre-screen patients with common general surgery diagnoses. Prior studies in the primary care setting have suggested that there is less information exchange between patients and physicians during video and telephonic visits when compared with in-person encounters. And to our knowledge, there had been no prior studies examining telehealth as a means for an initial consultation with a surgeon, especially in a non-urgent setting where these encounters, as we know, often involve a great deal of shared decision-making. So one of my research interests has been public perceptions in various different areas, but early in the pandemic, my research group and I set out to specifically examine how members of the general public felt about modalities for initial surgical consultations. So we used a crowdsourcing platform, Amazon MTurk, to survey a convenient sample of 2,000 people. We ended up getting 2,042 responses. We had some attention check questions in there to make sure that we weren't getting attacked by bots. And we ended up with about 1,827 responses that were analyzable. 72% of the people who took the survey had had surgery in the past, so they did have some experience with the system. Half of our respondents had had prior experience with telemedicine, with 60% of these experiences due to the COVID-19 pandemic. So that shows how quickly telemedicine touched a lot of people, because we did this survey in early April 2020. Of our respondents who had prior experience with telemedicine, most of them were satisfied with those encounters, and only 12% were unwilling to see their doctor virtually or see a doctor virtually again in the future. We then sought to understand whether people thought telehealth was an acceptable way to meet a potential surgeon. A convincing majority of our respondents were willing to accept telehealth for an initial surgical consultation as a temporizing measure under the unusual circumstances of the pandemic, but showed a general lack of enthusiasm to continue it once things returned to normal. And there have been at least 2 other subsequent studies echoing those findings. In order to determine why there seemed to be a preference for in-person meetings, we then asked about 8 key components of an initial visit to a surgeon. The majority of our respondents thought that the physical exam and establishing trust and comfort could best be established in person, and almost half thought that initiating or completing the workup would also be more effective in person. But for other components of the visit, such as history taking, discussing treatment options, and explaining the surgery itself, the majority of respondents thought that either in-person or telehealth would suffice. We found that there were no elements of the initial consultation that respondents thought would be more effective virtually. So next, we asked our survey respondents to consider 6 different surgical scenarios: total knee replacement for severe osteoarthritis, pancreatic resection for cancer, thyroidectomy for cancer, inguinal hernia repair, cosmetic rhinoplasty, and lipoma resection. And we wrote up layperson descriptions of these so that they knew kind of what the operation they could expect would be and what the implications of the diagnosis was, including the urgency. So during social distancing, most respondents preferred telemedicine, and we were really interested to see that there weren't a lot of people, even for the very elective things, who wanted to wait until social distancing ended or defer their care. Most of them wanted to get care no matter what. There was still a substantive minority, though, even during social distance restrictions, who would rather meet their surgeon in person across all 6 of these diagnoses. Not surprisingly, the preference for an in-person consultation under both normal and pandemic circumstances was highest for pancreatic cancer, and it did generally trend upward with the increasing severity of the diagnoses. But interestingly, we found that the preference for in-person versus virtual visits, especially under normal circumstances, was not particularly disparate with varying surgical complexity. So there's obviously further work needed to understand why this is, but we hypothesize that it's really the patient's desire to establish a relationship with their surgeon that's driving their preferences, rather than factors that are specific to the underlying diagnoses. And since one of the potential benefits of telehealth is the ability to potentially have support people join the initial conversations or appointments, even if they don't live near the patient, we hypothesized that we might see more enthusiasm if we asked our respondents to pretend that they were the caregiver for a loved one who could participate in a virtual visit as an initial consultation and see what their preferences were if the patient was not themselves, but their loved one. And we were kind of surprised actually to find that there was no difference in the preferences for in-person versus virtual visits when considering their own care versus care of a loved one who might live remotely. So in our study, we also asked about the importance of an in-person meeting prior to having an operation. So nearly 3/4 of people believe that it was extremely or very important to meet the surgeon and to be examined prior to the day of surgery. Interestingly, we sort of flipped this question around and asked, how important do you think it is to your surgeon to meet you? And they did not seem to think this was as important to the surgeon as it was to them. So other work has begun examining the shortcomings of telehealth in surgical practices when it comes to patient satisfaction. This is a work from an otolaryngology group demonstrating that video visits scored less well than in-person visits on several factors, particularly related to interpersonal communication. And this was an interesting study looking at Press Ganey patient satisfaction scores for over 38,000 visits. And I think this one perhaps best underscores the fundamental importance people seem to place on establishing initial rapport in person. So when they reviewed these 38,000 visits, they found that patient satisfaction was better for telehealth for every single visit type except new patient visits. So while I was in the process of doing and designing this study, I was also myself doing a lot of telehealth clinic. And as an endocrine surgeon, most of my referrals have thyroid or parathyroid disease, and they come with a fairly complete workup. Most of them go to surgery. And in fact, in many ways, I thought my practice can be quite algorithmic in a way, and I thought kind of seemed tailor-made for telehealth. And indeed, I found that telemedicine visits were really good for exchange of information, a decision that the patient was a good candidate for surgery, and discussion of the operation itself, including risks and benefits. I thought that telehealth clinic was going pretty well. We would then set up an in-person visit for us to meet and for me to do an ultrasound before taking the patient to the operating room. And I would tell people this is going to be a quick 15-minute visit to shake hands, sign consent, and do an ultrasound. And instead, I really found myself stuck in a really inefficient cycle. And so both the patient and I repeated all the same conversations when they would come in for this purportedly quick office visit. So that made me think, at first I was the one telling my patients that I needed to see them preoperatively. And I started to wonder, was this visit for me because that was traditionally how I had practiced, or was it for the patient? And so in appropriate cases, I started offering to book their surgeries straight and going to the operating room after our virtual visit. And I only had one person take me up on it. Almost everybody's response was, yeah, thanks, but I'd like to meet you first. And so as soon as I could, I stopped offering telehealth for initial consultations to reduce this or avoid this redundancy in my practice. So it seems I wasn't the only one. This is data from Dr. Ellimoottil and specifically looking at new patient visits in surgical subspecialties based on insurance claims data in Michigan. And so the yellow line down below is showing that obviously telehealth use peaked or climbed rapidly at the beginning of the pandemic, but then has declined since, though still remaining higher than it was before the pandemic. And I'll let him speak more to his own work, but the reasons for this are likely multifactorial, including system, surgeon, and patient factors. But I wonder, how much of this is being driven by patient preference. So understanding our patients' opinions is going to be key in moving forward with increased utilization of telehealth. Our study was not set up for a robust qualitative analysis to actually get themes, but we did allow respondents to enter free text comments. And their responses really seem to fall under 4 main topics. Telemedicine is an acceptable alternative during the COVID-19 pandemic, but is not the preferred way to see a surgeon. There were some concerns about technology and data security related to telemedicine. Some people thought telemedicine should become a permanent part of our healthcare system because of its time and money-saving benefits. And others thought that telemedicine, sorry, I can't go backwards. Others thought that telemedicine was appropriate for uncomplicated concerns, but not for more serious issues like surgery. So I focused so far really on the perspective of the majority of people who seem to prefer in-person surgical consultations whenever possible. But I think it's important for us to remember that 1/3 of our survey respondents preferred a virtual platform for an initial consultation, even under normal circumstances. So while that was a minority, that's still a lot of people. So what's less clear is whether people would be willing to accept a telemedicine consultation as their only preoperative interaction with their surgeon, or whether, as I experienced personally, they would expect an additional appointment to meet in person prior to proceeding to the OR. Obviously, if this were the case, it would potentially introduce new redundancies and system inefficiencies. But remember that 1/4 of our survey respondents did not seem to place great emphasis on meeting their surgeons in person prior to the day of surgery, suggesting there are many patients who may value the convenience of telehealth over the potential benefits of establishing in-person rapport. I think there's a lot to be learned about the value the public places on telehealth. Our survey asked only one single question about cost, just really to take the public temperature of how much they value telehealth. And most respondents felt that telehealth should cost less than in-person visits. So future work is obviously needed to explore the impact of the respondent's insurance status and out-of-pocket costs and exactly what's shaping this perception, but there does seem to be some reduced value that the public places on telehealth. So while much more research can and should be done about telehealth and surgery, I think accurately measuring the contribution of the intangible human elements to the therapeutic relationship we have, it's elusive. But going forward, a thoughtful integration of virtual and in-person care will be necessary to take advantage of the benefits provided by technology, while also preserving the important human connection that forms the foundation of trust between surgeons and our patients. Thanks so much. It's been a lot of fun to be part of this panel, and I'm looking forward to everybody's questions.
Thank you, Dr. Sorensen, for providing us with important patient and public perspective on everything we just talked about. And I think between the three of our speakers, we have covered most aspects and considerations around telehealth. We'll open the floor now to any questions from the audience. And for anyone who would like to ask the questions in person, you can use the raise hand button and I can unmute you. And maybe I can start with the first one while the questions come in. Dr. Sorensen, when I initially read your paper in Annals of Surgery, I was very intrigued by the use of MTurk as a platform to survey public perception, which is incredibly important. I want to get your thoughts on and your experience with using the platform. Is there any potential sampling bias that we need to contextualize the responses with? Like, is it a younger, more tech-savvy audience that you're capturing who may be more open to telehealth? Or if attentiveness was an issue for the survey?
Yeah, absolutely. This is the second study I've done using Amazon MTurk, and it's an incredible tool in that this particular study took us about 2 days to get 2,000 responses. The other study I did, we got 2,000 responses in 4 hours. So it's a really powerful tool to get a huge convenient sample. As you point out, 80% of our respondents were under the age of 50. So, I actually thought 20% over the age of 50 was pretty good. But it's definitely skewed towards a younger audience, which I think particularly for any of these healthcare studies are not necessarily putting us realistically in the group that are facing these decisions. And specific to this study, it's an obvious limitation because anybody who's a participant in Amazon MTurk is probably going to be more enthusiastic about technology like telehealth. So it probably is not completely generalizable, but I think it is a powerful tool. And if this particular population had some hesitations, we can extrapolate that the people who are less tech savvy probably have those magnified.
I think it's amazing. I think as we transition more towards a patient-centered efforts, I think sampling the public's perception is going to be increasingly important. We have a question from Jeremy. This is for Dr. Reinke. It is wonderful that you were able to complete a randomized control trial on the topic. How generalizable do you think your findings for post-op follow-up are to more complex operation? Would it be any different for patients with drains or even skin staplers for that matter?
Yeah, so that's a really interesting question. For this study, patients with drains or skin staplers were excluded because we can't take those out virtually at this moment in time. Actually, our initial foray into this was virtual wound care with home care nurses. And so there's potentially an ability to sort of put those two together to make it actually feasible if the benefit was out there. So those patients weren't here. We've done some of that work separately. And then a lot of my colleagues who do the more complex surgeries were adapting this into their care. So for our HPB surgeons, they actually use the NSQIP risk calculator, identify patients as medium, low, high risk for postoperative complications, and then define their postoperative follow-up. And for those who get weekly follow-up, they're alternating. They're doing one virtual, one in person, one virtual, one in person. So I think there's, as we sort of talked about today, probably a million ways to do it and no one right answer. But I think it can probably be used in a variety of different settings depending on the needs.
Perfect. And then the last question for Dr. Ellimoottil. Your study demonstrated that one of the strongest predictors of not using telehealth was patients who needed an interpreter. Is there any platform, whether it's on Zoom or any other interface that has an interpreter plugin option that makes it more intuitive and help those population of patients who need it?
Yeah, that's a really good question. Actually, the Zoom platform, depending on the interpretive services that you have, the Zoom platform does allow for it. Even back then, when we did the study, if I logged on with a video visit with a patient who needed an interpreter, that interpreter was already there. So they had, they were just on a different screen. So at the time of our study, we actually had all those capabilities. So I think needing an interpreter is actually a little bit deeper. So if you need an interpreter, it may be hard to schedule that patient. So you have a person on the other end that's doing the scheduling who has 15 other patients to call back. Like the time it takes to go through this with an interpreter, or the patient that has English barriers may be harder. So I think that it wasn't actually interpreter services, those are available. It was more so the fact that it was likely more other factors that drove that difference. So I think that's important to think about as we kind of think about like structural problems and that type of infrastructure and kind of cognitive biases, subconscious biases, and so forth.
Perfect. I was just going to ask if there's an added cost to having an interpreter on the Zoom platform, but to your point, I think that's beyond. That's not the main issue of engaging patients who actually need access to care. So we're coming up on the hour now, and I'd like to respect everyone's time. A quick public service announcement for all who's logged in now. Please consider joining AcademyHealth and the Surgical and Perioperative Care Interest Group if you have not already. The link to join our group is listed in the chat, or you can email Dr. Angie Ingraham at her email listed in the chat as well, and we will add you to the email listserv. Our group's meeting, which will be virtual this year, will be on Thursday, June 17 from 11 a.m. to 12 p.m. Eastern Time. So on behalf of AcademyHealth Surgical and Perioperative Care Interest Group, we would like to thank our invited experts, Dr. Reinke, Dr. Ellimoottil, and Dr. Sorensen. And I personally would like to thank Dr. Caroline Thirukumaran, who was my co-moderator, who was instrumental to this webinar, but unfortunately could not be here today. And as a reminder, the link to the recording will be emailed to all the registrants and will be available on our website shortly as well. Thank you, everyone, and have a good evening.
Thank you.
Bye.